and free of extrapyramidal side effects, free of weight gain, and free of prolactin elevations, and should strongly be considered. Let's move on to affective disorders. Major depression is extremely common, affecting 15% of men over the course of their lives, 30% of women. In approximately 15 to 20% of those who have a major depression, psychotic features are present. If the FDA has approved aripiprazole as an adjunct treatment for major depressive disorder, other supportive evidence for risperidone, for quetiapine has been submitted. The expansion of these drugs into this market will lead to a great number more patients receiving antipsychotic drugs at great cost if we focus only on the newer atypical agents. It is important to keep in mind that older studies clearly documented that adding perfenazine to amitriptyline led to higher rates and greater degrees of therapeutic benefit than using amitriptyline alone in people with serious depression. And there has been no systematic study done that would suggest that the newer agents offer any greater value than adding, again, perfenazine, loxetane, molindone, or another drug like that. The advertisements on television suggesting that, for example, Abilify, quotes, might be right for you, is leading to patients coming to doctor's office asking for newer atypical antipsychotics when information is available suggesting that these drugs are not as safe as was originally thought, and that their benefits in these indications are at best modest. Over the past several years, it's been shown by Marvin Swartz and Marissa Domino that the increased usage of antipsychotic drugs is not among individuals with psychotic disorders, where the percentage of people labeled with these disorders has stayed about the same, and the percentage use within the psychotic population has remained about the same. What has changed is a substantially greater percentage of the population consider themselves to now have an affective disorder, and a substantially greater percentage of those who believe themselves to have an affective disorder are currently treated with an antipsychotic drug. We can only wonder to what degree marketing has influenced this. Let's talk briefly about PTSD, post-traumatic stress disorder. Some investigators believe this is a highly prevalent illness, again with 8% being an estimate of the prevalence in the population. It is predominantly experienced by women. The first-line treatment is an SSRI, but in the meta-analysis that I included in your booklet by Pei, P-A-E, et al. In 2008, there is the suggestion that moving to or adding an antipsychotic may provide some additional benefit. I think a careful look at that paper documents how tremendously modest that benefit appears to be, barely distinguishable from placebo, and being associated with substantial weight gain. If you look at borderline personality disorder, illness that is estimated to affect 2 to 3% of the general population, but may account for 25% of psychiatric inpatients and 15% of psychiatric outpatients. A recent review was titled Evidence-Based Pharmacologic Treatment of Borderline Personality Disorder, a shift from SSRIs to anticonvulsants and atypical antipsychotics. The title is interesting given from their own review the evidence that older conventional antipsychotics work, or appear to work to have a slight beneficial effect. So do newer atypical antipsychotics. My concern is the subtle shift, the glide into preferential reference to the newer drugs when there are no comparative studies that have looked at one of the newer drugs versus one of the older drugs and comparing both to placebo in the same trial. I will mention very briefly that a reasonable number of primary care physicians treat patients with psychiatric disorder. There has been increased efforts to market the newer atypical agents to these doctors. Many of these physicians may be delivering excellent care. There is not a problem with the issue, but what needs to be taken into account here is the continuing spread of use of these agents farther and farther and farther from the very small range in which adequate, sufficient quality studies have been done to support and guide their use. Off-label use, again, acknowledged, accepted by the FDA, has led to many advances in clinical care, but there is continuous progressive off-label use of the antipsychotic medications occurring over the past decade that warrants further and more careful study. A couple of brief comments on the conventional antipsychotic medications. They are extremely simple pharmacologic agents in that the entirety of their antipsychotic efficacy is explainable on the basis of blocking dopamine D2 receptors. At 60–70% of D2 blockade, therapeutic effect will appear if it's going to appear, and the degree of the blockade is determined not by how much drug you give, but by variables, factors within the patient, that individual's capacity to respond. Pushing doses above 60–70%, where often a very slight degree of rigidity may appear. Once you get up to 70–80%, you have coarse extrapyramidal side effects, Parkinsonism, tremor, restlessness. No more benefit occurs, and the downside of EPS, the need to use anticholinergic, anti-Parkinson meds that are usually incompletely effective and have problems of their own unfolds, and you're telling people to take medicine, a medicine combination, if you don't reduce the first-generation antipsychotic dose, that's making them feel slow, feel stiff, and then adding something that makes them constipated and have blurred vision. And it just does not seem reasonable to ask a patient to continue taking such a combination. Clozapine, initially brought to the U.S. for study in the early 1970s. The impression of greater efficacy and an absence of EPS initially led to great interest. The drug was withdrawn for several years because of agranulocytosis, but brought back through the combined efforts of several academicians and Sandoz Pharmaceuticals. A number of studies have consistently documented the superiority of clozapine above other antipsychotic medications, not only for treatment refractory psychopathology, but also in reducing violence, managing suicidal self-destructive behavior, for compulsive water drinking, and in all likelihood for reducing substance use. Clozapine has a number of side effects. I'm not going to go into these at this time. All are manageable. A point I would make is that clozapine probably should not be used by every psychiatrist, certainly not by psychiatrists who might use it once a year or once every 2 years. It requires familiarity with the monitoring procedures, with the routines that are needed for early detection of agranulocytosis.